Good afternoon, everyone. Welcome. I am Patrick Teig. I am the Health Insurance Commissioner at the State of Rhode Island Office of the Health Insurance Commissioner. I'm really pleased to invite and welcome all of you to today's Rhode Island Healthcare Cost Trends Project community meeting. I would like to start by just acknowledging the support of the Pearson Center on Healthcare for, again, providing the resources for Rhode Island to conduct this very critical cost trends work throughout this project. So thank you to them for that. At the outset here, I want to note a few things before we dive into the substance of the day. The first is just to note that this is the fourth large convening of the cost trends work on a public basis. And it's the result of years of stakeholder engagement across the healthcare sector and collaboration across our state. The engagement process has led the state to establish a cost growth target that was established back in 2018. And as a part of the establishment of that target, parallel action has been conducted to both, one, rigorously analyze the drivers of cost and cost growth, and two, facilitate collaborative action in addressing system performance improvement opportunities. So today we will hear how Rhode Island performed against the 3.2% cost growth target in 2019 and discuss opportunities for action to address the cost drivers and cost growth drivers that have been identified. We will also hear from my steering committee co-chairs, Dr. Al Caros, President and CEO at Coastal Medical, and Michelle Letterberg, Executive Vice President, Chief Legal Officer, and Chief Administrative Officer at Blue Cross Blue Shield of Rhode Island, about strategies that our steering committee has recommended and is considering related to healthcare cost growth and to make healthcare more affordable, as well as more accessible to all Rhode Islanders. We have reserved time today as well for open public discussion and questions from the audience, and we encourage everyone to actively engage in this important dialogue. Please use the chat box function or the hand icon to raise your hand to indicate that you have a question. And thank you all once again today for joining. So with that, I will turn it over to Megan Burns, Senior Consultant at Baylor Health. Baylor Health has been providing technical and analytic support for the Rhode Island Healthcare Cost Trends Project throughout its full duration. And Megan will begin by presenting our 2019 performance results at the state level and the market level. Thank you so much. Megan, please.
Thank you, Patrick, and hello, everyone. It's a pleasure to participate in this meeting today. Today, I'll be presenting the findings of performance against the 2019 cost growth target. And here is an overview of what I'll be sharing with you. First, I'll provide you with a brief background of why we're measuring total healthcare spending against a target, what the performance was at the state and market levels, and the measurement of the net cost of private health insurance. During this presentation, I'm not going to be stopping for questions, but as Patrick mentioned, we've reserved time after the panel discussion for public comments and questions pertaining to the data presented. So why are we doing this? The core reason we're measuring the trend of healthcare costs is because healthcare is unaffordable for many. And I want to provide you with an example. The Kaiser Health News and National Public Radio profiled the Cano family from Santan Valley, Arizona in late 2018. They're a family of three where both parents work full-time and they have a young child in daycare. Together, they earn nearly $100,000 per year. They have employer-based insurance and had no major illnesses or injuries. Since their son was born, they acquired more than $12,000 in medical debt and are on a $700 a month payoff plan with various providers. That's in addition to their $500 a month that they pay for health insurance. So I want to briefly pause here and have you hear their experience in Tiffany Cano's own words.
We really have been struggling with our finances just after having a baby. My husband's working 4+ jobs. I work full time. I have a prosthetic leg, so it's been really hard just taking care of my son on my own, basically. And we started getting a lot of medical bills. We have employer insurance, and I thought, that would be enough whenever we have a baby, but the high deductible and the co-insurance has been so much. We started getting bills after bills that we had to do payment plans on, and realized that they're not going to be paid off until he's 3 years old. And we're a hardworking family. I mean, 5 jobs between 2 people, and just the commute. We barely ever get to see our son. With the cost of daycare and these medical bills have just been outrageous. To now still have, I mean, like 10,000 plus in medical bills. It's just insane to me.
So the story published along with the clip that I just shared with you also shares that Tiffany is in need of a new prosthesis since her body changed during pregnancy and her old one no longer fits. She's delayed getting a new one because it costs between $10,000 and $15,000. This is just one story of one family in one state, but I think the story rings true in Rhode Island as well. We can see here from this slide that the Cano family story could happen right here in Rhode Island. Here you can see that worker contribution to insurance premiums have grown nearly 3 times faster than personal income. The graph shows per capita personal income, which is the dotted green line, and that's growing at a much slower rate than the total family premiums, which is the dashed blue line, and worker contribution to family premiums, which is the solid blue line. It also shows you that employee contribution is rising faster than the total premium because plan design is shifting some costs from employers to employees. And this is just one example of how healthcare spending growth is outpacing income growth in Rhode Island, making it more difficult for Rhode Islanders to afford healthcare. And so we're measuring healthcare cost growth because the first step to lower it is to understand it. So as you all probably know, Governor Raimondo's executive order back in 2019 set a healthcare cost growth target for 4 years at 3.2%. That cost growth target is measuring total healthcare expenditures, which consists of claims, non-claims, member cost sharing, and the net cost of private health insurance. In order to measure total healthcare spending, OHIC collected data from multiple sources. First, the 4 largest commercial carriers in the state, Blue Cross Blue Shield of of Rhode Island, Neighborhood Health Plan, Tufts, and United all participated in sharing the data. In addition to the carriers, OHIC also collected data directly from EOHHS for Medicaid fee-for-service expenditures and from CMS for original Medicare and Part D spending. In addition, we calculated the net cost of private health insurance. Net cost of private health insurance measures the difference between health premiums earned by the insurer and claims and non-claimed based spending by the insurer. The data sources for the net cost of private health insurance come from governmental filings made by insurers and some supplemental data that was also provided by some insurers. So now let me share with you the overall state performance and the market performance against the target. Rhode Island exceeded the cost growth target at the state level with a 4.1% trend, which amounts to $65.8 million in excess cost growth. This slide here is showing the per member per year of total healthcare expenditures, which includes all claims and non-claims based spending. And just to be clear, the non-claims based spending can be things like shared savings. It could be incentive programs for providers. It could be care management fees that insurers are providing to providers to manage a population. It also includes patient cost sharing and the net cost of private health insurance. As part of the measurement, we collected data on several service categories to get more information on what's contributing to the growth rate. And we found that hospital outpatient and retail pharmacy were driving spending growth in Rhode Island at the state level between 2018 and 2019. Now, I want to orient you to this chart. This chart is showing the unadjusted, meaning not adjusted for health insurance risk. It's a per capita trend on a state level, and it is net of pharmacy rebates. The width of the bubble represents the contribution to trend. So the larger the bubble, the greater that particular service category contributed to the trend. The height of the bubbles on the y-axis represent the per capita trend, and the location of the bubbles on the x-axis represent the per member per year spend on the service categories. So the higher the bubble, the greater the trend, and the farther the bubble is to the right, the more spending on a per member per year basis. You'll see a couple of these charts, which is why I wanted to slow down and explain what you're seeing. Later in the presentation, you'll see that hospital outpatient and retail pharmacy are common contributors to trend across the different markets, but they're not the only ones. We think this is an important finding, but we also need to remember that what's contributing to growth could change year to year, which is why it's important to measure it on this basis annually. Now I'd like to share with you the specific market performance of the commercial, Medicaid, and Medicare markets. Starting with the chart on the right, you see each of the three markets represented by a bar. The length of the bar represents the relative market size by membership. So you can see the commercial bar, there are more commercial members than Medicare. The height of the bar represents the trend. And then you can see by the dashed line is the target. So you see commercial and Medicaid were above and Medicare was below. The table on the left shows the per member per year values of each market. And here you can see that Medicare has the highest PMPY, but the lowest trend. Commercial has the lowest PMPY, but the highest trend. These data do not include the net cost of private health insurance. They are net of pharmacy rebates and spending on the population that is dually eligible for Medicare and Medicaid is spread across those two markets based on which payer covers what service. So let's dive into some of the details at each of these market levels. So first is the commercial performance. The commercial market exceeded the benchmark, coming in at 4.7%. This represents an excess cost growth of $31.7 million. Here we see the contribution to trend analysis for the commercial population. As a reminder, the y-axis represents the per capita trend, the x-axis represents the per member per year spend, and the width of the bubble represents the contribution to trend. 61% of commercial growth was due to hospital outpatient and other professional spending. So what is other professional spending, you might ask? It's claims to providers for services provided by a licensed practitioner other than a physician or other than a individual identified as a primary care provider. So it could include, for example, physician assistants. It could be nurse practitioners who are not identified as primary care providers, podiatrists, PT, OT, speech providers. It also includes psychologists and licensed social workers. Hospital outpatient was relatively expensive and had a 7% growth rate, whereas the other professional was more modest in terms of the per member per year, but it had a rate of growth of 16%. I want to note here that other claims and long-term care are not on this chart because they had negative growth rates. And just to be clear, other claims represented services that couldn't be categorized by the broad services of hospital inpatient, outpatient, professional spending, pharmacy, and long-term care. Moving on to the Medicaid market. The Medicaid market exceeded the benchmark, coming in at 4.1%. This represents an excess growth of $20.5 million. These data here are inclusive of Medicaid managed care spending and spending reported directly from EOHHS on fee-for-service spending. It also includes the Medicaid portion of those duly eligible for Medicare and Medicaid. And here again, you see the contribution to trend. And in this case, for Medicaid, hospital outpatient and retail pharmacy were the main contributors to the trend for the Medicaid market. And finally, I want to share with you performance at the Medicare market. Medicare per capita trend was lower than the target at 1.3%. This amounts to $53.3 million avoided if it had grown at the rate of the cost growth target. This is inclusive of all managed care reported spending and original Medicare or Medicare fee-for-service. All Part D spending is also included here, regardless of whether it was administered from a standalone prescription drug plan, a Medicare Advantage prescription drug plan, or otherwise provided to a Medicare member. These data are reported net of pharmacy rebates, but I do want to note that we didn't have access to original Medicare pharmacy rebates directly from CMS. So these figures might be slightly overstated because of that. So here again is a contribution to trend analysis by service category. And you'll see here that the hospital outpatient, retail pharmacy, and other professional equally contributed to the modest increase in Medicare spending. The corresponding decrease in inpatient spend was the most significant contributor to CMS coming below the target growth rate. You don't see that on this chart because it had a negative growth rate of negative 3.4%. And it's an expensive per member per year in terms of service categories. And so the decrease in the spending and because of the dollars it represents relative to the other service categories played a large role in controlling the Medicare growth rate. So in summary, hospital outpatient was driving the spend at the state, commercial, Medicaid, and Medicare markets. Pharmacy net of rebates was driving trend for all but the commercial, and other professional had a role in the commercial and Medicare markets. And we think that these are going to change from year to year, which is one of the reasons why it's so important to measure service category basis trend, and also to help us understand what may be contributing so that future solutions can be developed. We also think that further analysis of the breakdown of price, service mix, and utilization would also help shine some additional light as to the reasons why these service categories are contributing to overall spend. Finally, I want to share with you an analysis of the net cost of private health insurance. As a reminder, it's a measurement between the premiums earned by an insurer and the claims and some non-claims-based spending they do, like quality incentive programs, for example. There are 3 notes that I want to make, though, before I share with you the analysis. First, the trends are hard to interpret. That's because the financial data that's used to calculate the net cost of private health insurance don't give much insight into the contributors. So for example, we don't know if the net cost of private health insurance increased or decreased due to marketing. Did it increase because of use of quality incentive programs? Or is it because there were losses incurred in the previous year? We can't necessarily glean that specifically from the data that are used to calculate it. That being said, there's still some important information we can glean from the net cost of private health insurance. For example, it is pretty interesting to see the relative costs of administering private health insurance and how that varies by market segment, which I'll share with you in a moment. I just want to note that we caution overinterpretation of the information. Finally, the net cost of private health insurance is about 7% of total spending, and that's important to understand that, which is why we're sharing with it with you today. So here you see the relative per member per year cost of providing health insurance by market. The first 4 here, the individual, small group, large group, and self-insured are the commercial market. And you can see relative to, for example, the Medicare market, the commercial market is on a per member per year basis relatively less expensive than Medicare. Excuse me. And that's not unexpected because the Medicare Advantage market is capturing individuals members on an individual basis, whereas in the commercial market, it's usually working with large employer groups or even small employer groups and not marketing on an individual basis. Let me address, though, where your eyes may be going, which is the Dual's Financial Alignment Initiative, which is represented here at the bottom. This is Neighborhood Health Plan's integrity, And it is the only product in Rhode Island with a fully integrated Medicare and Medicaid benefits, including pharmacy. And the requirements for that particular product and the premiums are set jointly by CMS and Rhode Island Medicaid. And so what you're seeing here is that there were some significant underwriting losses experienced by NHP during the startup of the program. But those losses have been since mitigated through risk adjustment, and post 2019, NHP anticipates a more representative look of cost insurance, the cost of health insurance moving forward. So with that, I'd like to turn it over to Patrick, who is going to introduce our respondent panel for further discussion.
In that vein, I want to open up our first respondent panel of the day. This panel will be focused on a reaction to the information you all have just seen that was presented by Megan. And so I'd like to start by introducing the members of the panel today. First, I'll begin with Sam Salganic, who is the Executive Director at the Rhode Island Parent Information Network. We're also joined by Dr. Jim Finale, who is the President and Chief Executive Officer at Care New England. And then finally, we have Beth Roberts, who is the Senior Vice President at Harvard Pilgrim Healthcare and Tufts Health Plan. I want to thank all three of you for being here today and taking time to respond to this information and have a dialogue. And so I think I will start to frame my remarks, and then I'll turn to questions. We can have an open discussion. So what I would start, what it occurs to me in terms of sitting here and reflecting on this information as I see it here presented again, and really earlier in the day as well. The overarching way that I would frame it is really back to the question of affordability for Rhode Island consumers and employers. And as we all saw earlier, that since 2001, Rhode Island employee contributions to employer-sponsored insurance premiums, for instance, have grown nearly 3 times as fast as personal income. And so I think it really is clear that healthcare costs are taking up a greater portion of personal income and employer personnel budgets. And so as we learned from the presentation, between 2018 and 2019, hospital outpatient and other professional spending accounted for 61% of commercial growth trend in the commercial market, for instance. And so with that as context and the continued challenge of affordability for Rhode Islanders, I want to start my question with you, Sam, and really focus on, from your perspective, as you see the same information and recognize those affordability challenges for consumers. What would you cite from your perspective are the most important collective actions that providers, payers, the state, consumer advocates, and employers can take together to ensure that we don't continue to face the same level of affordability challenges that we see in this data today?
Thank you. First of all, thank you, Patrick and the other co-chairs and the folks who have been leading this work for so long. It's a great initiative to bring transparency to where healthcare spending is increasing and how. My immediate reaction to the data and thinking about what the data says about what to do next collectively is that it doesn't yet say enough. I think Megan mentioned briefly the idea of digging deeper, particularly to dig apart, to pick apart whether costs are increasing, the difference between price changes, service mix changes, and utilization changes. I think that's very important further analysis, because the collective action, the policy changes that one would want will look very different if the cost increases are driven by utilization versus if they're driven by unit prices or even difference in market share between higher cost and lower cost providers. So I think first step is that it would be really important to dig deeper into that data. The next step that I think is important is, and this came up in the data a little bit, where you'll see some items going up in spending that some people might consider sort of good, a positive sign. For example, non-claims costs like shared savings payments. That's been a multi-year initiative to move towards more non-claims costs. So that spending goes up. That might be a good sign, not a bad sign. And I also think it's really important to link this data think about how to link this data to quality outcomes, health equity, population health, because again, not all spending is bad spending, and I think we really need to take that next step.
Thanks for that, Sam. And I think kind of one follow-up question that occurs to me, again, in response to your remarks, as we think about that linking, as you're saying, of the cost and affordability challenge to the quality of population health and health outcome, do you have any initial thoughts on what types of strategies can we use to really ensure collective accountability for all of us here, for all stakeholders in the system, versus sort of shifting responsibility among us? How do we truly drive collective action together across both of those domains?
I think that you've taken the right first step, which is to be data-driven and to be transparent about how the data is being collected and to share that data publicly. I think that's people who have been working in healthcare for a long time know that the costs have been going up for a long time, and collective accountability has sometimes been hard to come by. And I think it's really impossible without transparent, publicly available data. So I think that's the formula.
So I think I'll turn to Beth now. Beth, we did see as well that pharmacy spending was a really significant cost driver, particularly across the Medicaid and Medicare populations for 2019. And we'll talk a bit later about actions that the steering committee has considered and recommended to address pharmacy spending. But from your perspective, having the extensive experience you have on the payer side of the world, what do you really see as the most significant steps that need to be taken to address not only pharmacy spending growth more broadly, but specifically the growth in prices that we see in pharmacy spending? That's really a driver there.
Well, thank you very much for having me today. I appreciate being here. So on pharmacy in particular, I would agree it's a considerable cost driver. It's something that the health plans study all the time. I would say I won't steal the thunder of listening or hearing more about potential legislation, but excited about the legislation on reference pricing. And I think passage of that certainly would go a long way. One of the things that we also look at regularly is it's difficult because pharmacy costs are not transparent. So the actual drug costs are transparent to consumers and across the board. And we truly believe that transparency would go a long way. There's also novel drugs is what people call them. So high cost new drug entrants that come in. And there's this terrific organization called ICER, Institute for Clinical and Economic Review. And they do a great job of looking at new drugs that come in to determine the value of that drug compared to the clinical effectiveness. Now, this was a little tough for people, right? Because it's an organization that's trying to look at that intersection of value. But if we start looking at that to derive formularies and to drive good thinking on the right drugs to promote and to try to connect to patients, that will certainly help on the cost side. I would say the last thing that we like to consider, and this is really a health plan strategy, and this is considered a blunt instrument, and not everybody likes blunt instruments, right? But we could certainly do closed formularies or restrictive formularies. We could do different types of authorization requirements. But again, those are blunt instruments and ones that are a little tougher.
Thank you, Beth. I think that's really helpful to understand the full suite of possibilities. And so zooming out for a second, more broad than just pharmaceutical prices and trying to engage on that, but really thinking about the types of partnerships that have to happen between payers and providers in particular to address cost growth and costs. What do you see from your perspective about the opportunities that exist in the short term and the medium term here in Rhode Island for providers and payers to partner together to keep per capita spending below the cost growth target going forward? And certainly welcome, Dr. Finale, your view, and Sam too on that as well. But Beth, I'll start with you there.
Sure, thank you. And I love the way you phrased it, because partnership is exactly the answer to the question. So what we have to do is really work towards that risk-based contracting. And said differently, not everybody is ready for risk-based contracting, but there's so many different ways that we can partner together between health plan, provider system, and even member. We call them members, patients, it's really important that we have all three parties engaged in care coordination, looking at services that don't need to be done. So dealing with overutilization, dealing with underutilization, and finding a way to partner together to bring the best forward. So we need to look at the high cost areas, the high utilization areas, and build unique programming around them so that all three parties are aligned. I also want to just say that I think it's important to consider prevention, wellness, and all of that. So I know on the health plan side, certainly we believe, even though it's always hard to determine ROIs based on this, getting people engaged early in their health and looking very carefully at keeping them well as that intersection of medical and behavioral health, all of that is paramount, I think, to success in keeping costs under control.
Dr. Finale or Sam, did you want to build on that's comments or add anything additional?
Yeah, I would add, and Sam, you want to go first? I would add, was this question I was prepared for? Is that I think that's right. On the risk side and the contracting side, I've always would really enjoy trying to do something that's globally capped, right? Because I think if you have a fixed spend and you give us a chance to manage that, we can do that. The real problem is what Beth alluded to. I can't take a global cap risk. If insurers want to say, we want you to be global cap and leave it with you, the unintended consequences of that, if it's a bad year, we're going to go under and you're going to be in trouble. So the payment reform continues to have to be an absolute imperative. We're really good at doing a lot of stuff. Listen to my preposition, 2 people, then 4 people. On the provider side, we do a lot of people. You look at the outpatient professional spend in outpatient hospital, it's not just hospital, it's physicians or providers doing stuff to you, sometimes not as much for you. And we've grown up that we think that doing stuff is good, when I would say sometimes doing stuff is not good. But we have an incentive-based system that says the more you do, the more you're going to pay you for. So to me, we have to deal with that one way or the other. And the last thing I'd say that Beth said is on the member side. Frankly, unless the members are involved and have some ability to, some control and some choice limitation, perhaps, you're not going to get the effect that you need to, because they still want things when they want them, whether they need them or not. So I think we talked about this till the cows come home, but at some point we've got to grasp it. We're not going to, I've always said, if you gave me all the money we're spending today, we probably don't need to raise any more money, because there's enough in there to spend. There's 20% of stuff probably we shouldn't do. So the waste factor from the baseline is something we need to pay attention, because then the increases wouldn't be as much of a challenge. Sam,
if you had something you wanted to add as well.
Sure. Yeah, I'm glad that Beth and Dr. Finale both mentioned how to bring members to the table. I think Dr. Finale and I, we sometimes disagree about the extent to which this is being driven by utilization versus other factors. But I do think we've done a poor job, all of us as a nation, at explaining to patients how delivery system reform can be impactful for them and bringing them to the table. So I'll just give a couple very silly small examples. Many people, sorry, Beth, many patients get frustrated by the administrative red tape associated with their insurance plans, prior authorizations, network restrictions, and the like. We're moving towards a system that's supposed to be putting accountability on the primary care provider, yet sometimes that red tape remains in place even when the primary care provider is accountable. Primary care providers prescribing a medication, for example, prior authorizations can still be complicated. So why don't we lift some of the red tape? If we're making the providers accountable, let's give them the authority and responsibility. And that's something that patients and providers can feel a stake in right away. Another example, we've talked about the reference pricing bill for pharmaceuticals. Right now, I understand the whole price of drugs is too expensive, but consumers experience their copays. And I found it interesting that these proposals that could have a really drastic impact on the whole price, the all-in price of drugs, don't at the same time directly speak to copays, and something that consumers would experience and consumers could get excited about. So this is just a couple examples, and I'm glad you talked about bringing members into both into the day-to-day things that can help make care cheaper, but also into the movement.
Thank you, Sam. So I think one more question that I do want to pose, and then we can certainly have additional conversation as well before opening up for public comment and question. Dr. Finale, question specifically for you. I'm sure, as you noted during the presentation, that one of the drivers that we saw the high rate of spending growth above the target was in hospital outpatient spending specifically, and that was across all three markets: commercial, Medicare, and Medicaid. So do you have any thoughts about, from your perspective, what you think was likely the driver of that, recognizing the kind of analysis Sam proposed earlier is something I think we all recognize we absolutely need to do to decompose it further, but just based on your experience of really being at the center as both a hospital executive and a physician, just any initial thoughts you have on what might be a driver there, and then what could be productively done to help address that prospectively.
Yeah, I think one minor point on the Medicaid side is from 18 to 19, there was actually a change in attribution, if you remember, for the IHHH patients. Remember that? Like on our side, a lot of them were attributed to the Providence Center. Now they're in the ACO. So you'll find in the Medicaid outpatient, we saw, if I dug down into the ACO data, it went up like 13%. That was an attribution piece. It still went up 8%. It was still high. Okay, it's only a small piece. But I think it's the continued use of outpatient utilization. You have too many specialists, you have too many people doing too many things. And Sam's right about the accountability of primary care. But Sam, the only issue is we're not as accountable as we think we are. Because even though we're in these ACOs and we work with our primary care physicians, and we look at the referral data, we look at how many people refer, we try to cut down on the number of referrals. One thing we've done, for instance, on the cardiologist side, if you refer to a cardiologist, doesn't mean the cardiologist needs to see them 2 to 3 times a year, because every time they see them, they do something. But I think it's a continuation, Patrick, of the same high referral pattern to specialists that really clinically is not indicated. And until we get control on the payment model that we actually can say no. You also, Sam, and I think Beth would say, you might be alarmed. The primary care physicians that complain about the prior authorization, as soon as they're told responsible for the care, they put more restrictions in to make sure it works. But the good ones, because you stay within your network. So in conclusion, I think it's a continuation, the same pattern of we're used to doing stuff, we're used to ordering stuff, and people don't think they don't need to do as much.
Thank you, Dr. Finale. That's very, very helpful. So I think unless Beth or Sam, you have anything additional you want to add, I can shift us to open it up to questions for the panel from the audience.
I just wanted to add, I agree with Sam and Dr. Finale as well. I mean, you are absolutely correct that it is very difficult to put in additional authorizations, additional cost share, as we saw in the video earlier. All of that people see as barriers, right? We would love, as much as everybody else, a very streamlined system. We've studied it a lot where we have provider partners that we've had very strong relationships with, and we look at potentially what we call gold carding, saying you've proven that you've done really well with managing care, so we're going to take all of those administrative policies away, and costs go up a lot. And so we have to get to a more mature system in order to get there, and we would love nothing more than to get there, because I think the world will work easier for a lot of us if we can do that.
I think that's incredibly insightful, Beth, so thank you for that. So I'll remind the audience, please, for questions, the channel to do those, you'll see at the bottom of your screen is the Q&A button specifically. So please, any questions you have for the panel while you all are entering your questions, I'll thank the panel again for answering these initial questions and for being here today. And we'll open it up now through the Q&A function. Please, if anyone in the audience has questions for the panel, we do have some remaining time and we'd welcome you bringing those forward.
Patrick, it's Michael Baylett. There's one question that perhaps Jim and or Beth could respond to. Lou Jancola wondered whether the increase in outpatient hospital utilization could have been impacted by a movement from inpatient care to outpatient care. Jim and Beth, do you think that's a major factor here?
I'm glad you asked that question. So I'll comment. It is interesting to see the bubble chart, for lack of a better way. I'm sure there's a more sophisticated way to describe that chart, but I'll describe it as the bubble chart. It is pretty stark that the inpatient increase has been much smaller than that of outpatient and pharmacy. And I think it's exactly that. So it gets back to Sam's earlier comment is, some of the shift in utilization is sometimes really good. And in this case, and that's why we need to dig into the data a little deeper, because if we are keeping high cost inpatient care lower by keeping people outpatient, they're probably happier patients being outpatient than they are inpatient. It may be good, but it doesn't avoid the fact entirely that we're still going up in healthcare cost at a clip that none of us can really afford. So we still have to work on lowering it, but I think the observation is an accurate observation.
I would add yes, but. So yeah, it might be a shift, but they're still too high to begin with. And so you might be getting exactly what you want. We reduced inpatient use, but we increased the outpatient use, but the outpatient use was too high to begin with. So and we knew the inpatient use was high. We all knew that. I mean, so I would just say that I still think the shift is obvious, as Beth said, but they're still too high to begin with. So anyway. If you look at our utilization compared to other parts of the country, it's pretty damn high.
It looks like Dr. Kuros, you wanted to jump in here, so please do.
Yeah, thank you. I was interested in Dr. Finale's comments about referrals and the heavy use of specialty care. And I wonder if there's an opportunity in all of this work for us to sort of reconsider or reframe the relationship between primary care and specialty care. There's a difference when a primary care physician refers a patient to a specialist for advice on the treatment of a condition versus actual management of that condition. And I'd be curious Jim, to hear your comments on that, because it seems like that might be part of the utilization pattern that we're seeing.
Yeah, Al, I think it is. I think what Dr. Kuros is saying is that we send you to a specialist to consult, but they tend to keep you and manage you and keep seeing you. That is part of our problem for sure that we've noticed, and we've tried to put in guidelines and pathways to say, just send them for advice, not for management. You manage. That said, one way to begin to address the cost, and if we could have one of the health plans have the system to do this. For instance, I would love to be able to say on a risk deal, I like to subcap the cardiologist. Okay, I like to say the last spend last year was, Beth, $15 PM. I'll cap them there. Now we have to worry about leakage, but just cap them. And Al, they can see people as often as they want. But guess what? I don't think they'll see them as often as they want. I think they'll see them the times they need to see them. You always have to be careful about under seeing people. But I'd love to begin to starting subcap specialists to be able to reduce this spend. I don't know if you've done any of that out at Coastal, but it would be an interesting, I would love to try to do that, is to manage some of the spends. Where I was before in Springfield, for instance, one of the Medicare Advantage projects we had in the early 2000s, we subcapped the ophthalmologist. Guess what? Only the right number of cataracts got done. Only the ones who were needed got done. And we controlled the utilization of cataract. Because back then, it was almost like the presence of an eye meant you needed to have a cataract done. Because again, we incent fee for service, but subcaps at some of the specialty cares. And Beth, I don't know how much you guys have done that throughout your region, but it would be an interesting way to begin to get control of this. And we'd love to try to start doing that.
I think certainly all things should be on the table for consideration. So we've even looked at things like, can we figure out a cap amount for diabetes patients? Yeah, things of that nature, so that you can have an inclusive treatment cost. And so we're open to all of those conversations. I can't say, I think back, I've been in this business way too long, but way back when we were really sophisticated in full capitations and then subcapitations, we had a lot of that going on. Yeah. I think some of that has been dismantled over time, but re-looking at that, I think is certainly makes a lot of sense to me.
I sometimes, I get nervous about interventions that are purely focused on utilization. So Dr. Finale, I take your point that maybe utilization here is higher than in other states. We have a healthcare spending problem in our whole country. Even in the lowest utilizing states, we spend a high proportion of GDP on healthcare. And I think when you compare our utilization patterns to international utilization patterns, we are not particularly high utilizing. So I think there are other things happening too. And when we focus just on utilization, I think we very quickly get into the area where patients start to push back, their employers start to push back, the policymakers start to push back, and I'm not sure that it's adequate to addressing the challenge either.
Yeah, we won't debate this. I think it's part of it. I think you also have to look at the basic structure, and I'll use Rhode Island as the example. We've got a basically flawed funding situation in the state. And the commercial payers are subsidizing the Medicaid payment. I'm not picking on Medicaid, Patrick, I'm not. But when Medicaid, when we look at my own situation, where you're running 8,000 deliveries a year and 3,500 are paid at a remarkably below cost. I don't know how to keep a women's hospital in the state of Rhode Island open for 8,000 deliveries and also take care of a NICU if those payment rates are not adequate to support the staff that's required. I don't got a lot of people running around doing stuff that need to be done. So I think we have a fundamental, the Maryland system is probably not a bad system where it's constant payment rates across all payers. That would be a nice system for the state of Rhode Island to look at. See, is there a way to look at the Maryland system where Medicare, Medicaid are here, commercials are here, same payment, budget might care for the year, and try to do it that way, because I think that's an interesting way to do it. And it's a cost system, right? And the cost will help drive the right amount of care and utilization. So unless we look at an enormously different way of a payment system, I don't know how we're going to be able to be resilient to serve the needs of the people in the state. And there's not enough money to go around, but we have to shift how we use it.
No, I think, Dr. I think that's the last part of your comment. I think I would underscore that personally. I think that's particularly important. Is it an all payer rate setting approach that has very strong quality incentives associated with it. I think does hold a lot of promise conceptually, and is something certainly that should be part of our dialogue. Yeah, so
I think it would be an exciting thing to do in the state of Rhode Island.
So we have a number of you all have elicited a large number of really interesting questions. So we're gonna try to get through as many as we can in the time we have before we have to turn to the next panel, which I think will also be a really constructive and interesting dialogue. So I'll just turn to the first quickly. This is from Stephen Lampert, who asks us a question about retail pharmacy spending. And I think, Beth, I'll direct this toward you. Any sense from the analysis you've done, for instance, internally, about which classes or a particular class of drugs that you see as consistently driving increases in pharmacy spending?
Oh, I wish I had more pharmacy depth of knowledge. I can't answer that, unfortunately, and I really apologize. I can certainly get back to anybody because our pharmacy experts absolutely do know. I mean, we certainly have seen an increase in behavioral health type drugs. That's unquestionable. And what we classify as specialty drugs, but that's not retail. That's in a different class on its own. But unfortunately, I can't go into more detail. I apologize.
No worries. That's still quite helpful, I think. So another question that's posed by an anonymous attendee is, and Dr. Finale, I'll direct this toward you to start. Question is, to what extent do you believe that hospital-based urgent care centers are a significant driver in that hospital outpatient growth category versus other types of drivers?
Yeah, so thankfully I don't have any of them, so I can comment freely. I think urgent care centers cropped up for one simple reason: people wanted access and they weren't getting in their primary care offices. I think urgent care centers have flourished and they thought that would reduce ED use. It didn't work. All it did was increase more and more people going to more and more care. I think we have to address this through different models of care, primary care, and have open access for folks. But then again, people are so used to going to urgent care. We developed an on-demand urgent care access. It was telehealth access for employees. Instead of running somewhere, they can call us and we'll see if they need to go somewhere at night. It wasn't utilized. So I think we have to look at totally new approaches where people stick with their primary care office, don't go to urgent care centers, and don't go to emergency departments, because I think they're way overutilized. We don't have any, so I'm not biased either way, of course. But I think, for instance, I think some of the stuff that Coastal has done, where they have a site for all of their patients, that's a good model, right? You got our site, come to our site, but it's within their practice. It's not a separately licensed facility. At least, Al, I think that's what you have.
Thank you, Dr. Finale.
Yeah, that's accurate, Jim. Thanks.
Thank you, Dr. Gross, as well. So Sam, this next question, I think, is something that I think you would probably like to opine on. So Deb Horowitz asks that, notes, first of all, that, Rhode Island historically and continues to be a pretty, in terms of insurance design, in contrast to other states, like, for instance, Massachusetts, is a very PPO-driven market versus a more tightly managed HMO market historically, and in the way those are traditionally understood as product designs. And so I guess the questions from your standpoint, Sam, is that an issue that needs to be addressed? If so, how? Or is that a focus you would say, no, that's actually the wrong area to focus on?
It's a hard one. I don't know how it came to be that way, or why that's historically happened in Rhode Island. And I also think it's interesting that that's happened in Rhode Island, because we have only a few carriers here, and we have a high degree of overlap in providers accepting many providers in Rhode Island accept all of the large plans that are offered in Rhode Island. And I used to work in New York, where it was a totally different planet. And so I'm not sure how impactful the HMO model would be. We do believe in patients using primary care appropriately. I think that's important for patients. And but I'm sorry, Deborah, I wish I could say something smarter. But it's, and whenever there's movement in this direction, I think the challenge has been that employers aren't taking up the plans, and it's hard for me to know why or why not.
I would comment that, this is not an HMO market. So generically, I'm not sure whether switching to an HMO platform will do anything. I think the philosophy and culture of this state is anti-HMO from employers everywhere. It's kind of ironic. The employers really want us to do more and more to reduce their premiums. And believe me, I'm a big employer. I pay $120 million a year in healthcare costs for my employees. But people don't want choice limited. They don't want to go there. So it's an imbalance kind of thing. Whereas in neighboring states, it's been sort of in the DNA. Massachusetts, Beth, it's been there forever. So there's more control over that spend, and theoretically it might work. But this is a PPO state. It's not an HMO state. People don't want to pay what it costs, and it's way too expensive, but then we don't want to limit choice.
So if I can contribute just a couple comments on this, we have one other state. It's a bigger state than Rhode Island, but Connecticut market is largely PPO as well. And there's a lot of competitors in the Connecticut market. But I would say there are absolute benefits to HMO. And when we look to our provider partners, network partners, to go into risk-based contracts, it is abundantly easier if you have HMO, because we can work alongside that provider community to keep the care directed in a way that allows the patient to have good access to care, continuity of care, and frankly, guidance and direction from a primary care provider. So we're huge supporters of HMO products. We are actually introducing our fair share of them in Connecticut. And we're starting to see in Connecticut that the HMO market is starting to grow a little bit, because it's relieving some cost issues in the state where more affordable products are coming forward. So it's hard because they're 100% PPO as well. And we came in with HMO, we grew very little, but we've been playing around with some of the products and seeing some small traction on it. So we can continue to share that information with Rhode Island if it's helpful.
That's great. Thank you, Beth. Well, I think unfortunately we did a few more questions, but I think we are at time. So I want to once again thank all of you for taking the time out of your day to participate today. I think this was a really, for me, it was an insightful discussion. I know I learned a lot, and I'm sure our audience did as well. So thank you all. I very much appreciate it.
Thank you.
Thank you.
Thank you.
With that, I will turn it over to my co-chair colleagues, Michelle Letterberg and Dr. Kuros, who are going to lead a discussion around the Cost Trends Steering Committee strategies that we've considered to address growth. And I would just note for logistical reasons to note that there will be additional opportunity for further public conversation and questions following their presentation. So with that, Michelle, I'll turn it over to you.
Thank you, Commissioner. Dr. Caros and I are going to talk about some of the comments that have been made earlier about the cost mitigation strategies and efforts that the steering committee has pursued or is considering pursuing, addressing specific cost drivers. Some of them were referred to by our speakers earlier. And then also some macro level strategies that focus on multiple drivers that the committee has started a conversation around. And so with that, yeah, perfect. So we've talked about the cost growth target is really the proverbial stake in the ground, providing an impetus for collective action. I think setting a public target is making a public declaration like was done in 2018 really helps set some public accountability towards an end. It's an anchor that establishes an expectation, and it can serve really as a basis for transparency, a place to start. The intention is ultimately to be able to provide, ensure, and accountable care organization, accountable entity level data. We were not able to do that this year, but the expectation is moving forward. We will be able to do that and create that level of transparency. But to be effective, the cost growth target itself is not enough. And I'll talk a little bit more about this, but it has to be complemented by strategies that really address the cost growth. And so if we can turn to the next slide. So it's really a multifaceted logic model, and all of our speakers today have referred to this. And so you start with measuring performance relative to the cost growth target. So the first step, you get to the target, which was publicly declared at the end of 2018. And has been presented earlier, really the details around what are the cost trend growth drivers. And we had a great presentation today that really went over what those were for our latest data. And that's important to understand because as was indicated, it will change from year to year. The report is what you have seen today, and it's really helpful, and it creates transparency and it creates accountability to understand what the cost growth drivers are and for the community more generally to understand that. And then from there is really talking about what are those opportunities based on the data to impact and slow cost growth. And then once you identify those with analysis, then the really difficult work is how do you implement strategies that can slow cost growth? And the strategies take a number of years to be successful. This is a long-term problem that took many years to get where we are. And it's going to be many years to be able to really have an impact. And I think all of the members, I think on the cost growth trend strategy committee, steering committee would say that kind of collectively agreeing to what the right strategies are has been a really difficult process. So I'll talk a little bit about how we've gotten to where we are. So there's been, the discussion today about analyzing the data to identify the cost drivers. And we've gotten to a place where we looked at and determined, pharmacy costs were a place where there was a lot of analysis done because that was a big driver between 2018 and 2019. And what we found is that the primary driver of growth in pharmaceutical spending was actually cost. So even as the utilization decreased or remained flat, prices drove up total spending. And so the steering committee recognized the need to take action on addressing the total cost. And a number of our earlier speakers referred to some legislation on reference-based pricing, which is something the committee did consider, but the steering committee felt it was important to try and work collaboratively and pursue strategies that other states are pursuing, particularly with concerns around the impact of taking strident action and impacting the pharmaceutical industry. So the committee, after a number of conversations and multiple meetings, recommended that Governor McKee pursue pharmacy price legislation that would impose a financial penalty on manufacturers that increase drug prices more than CPI plus 2%. As I mentioned, similar legislative action is being pursued in Connecticut and Massachusetts. There tends to be, with collective action, in many ways, it's more effective with more places taking similar action. I think, as Beth mentioned, different states have slightly different environments, but pharmaceutical growth, we know, pharmacy price growth, we know nationally is an issue. And so that letter did go to the governor, and the Cost Trends Project is now performing a deeper dive analysis into another area which was identified this year, which is hospital outpatient spending, to understand what are the components driving that spending growth there, and how does that inform more targeted action in that space as well. And before we move to the next slide, I would just emphasize again, legislation is a multi-year process. I'm sure in many states, I'm more familiar with Rhode Island, but you don't just introduce legislation in 1 year and it gets passed. So it will be a multi-year process and piece of work to try and get legislation passed that makes sense to impact price growth. And then, as I mentioned, there are targeted strategies that the committee has been considering, but that really will only have an incremental impact on cost growth. And so the way to have a really much more meaningful impact on cost growth is to look at interventions that are more broad-based. And one of these is something like advancing value-based payment models. As our panel talked about earlier, both Dr. Finale and Beth, I think Sam mentioned as well. And Rhode Island actually has made some progress towards value-based payment with the impetus help of the Office of Health Insurance Commissioner. So at this point, we actually have more than 45% of commercial payments in alternative payment models. So that's progress, but really there's more, that there are opportunities to do more. And we really need to advance these alternative payment models that transfer more financial accountability for costs and quality to providers, including non-fee-for-service models. And I think Dr. Finale made clear that the way the system is set up is, you get paid for the services you provide. And so we need to create different incentives, understanding also, as Dr. Finale pointed out, we have to be careful about transferring too much risk in a way to make sure that providers are financially sustainable. And so those are things we need to be mindful of, but really advancing these value-based payment models. And we know from other states that are more advanced in this areas really can have a material impact on slowing overall cost growth. And so at this point, and was agreed to at our most recent steering committee meeting, we are convening a value-based payment subcommittee that will develop strategies to accelerate the adoption of these value-based payment models. And we'll be working with external subject matter experts who will participate on the subcommittee, and then come back with a set of principles to guide the process with a more concrete action plan. And so that's really where we're at. I'd like to turn the meeting over now to Dr. Caros, who will talk a little bit more about next steps.
I think what I'd like to do is just take a moment to share a reflection or two. It's interesting, cost growth mitigation strategies is work that payers have been doing that regulators have been doing, that providers, particularly providers who are already under value-based payment, have been doing. But I think, maybe the magic in all this work that we're starting to experience and hope to have a lot more of is, what's different here now is the collective nature of this work, the collective accountability that's been discussed, the collective strategic emphasis and new initiatives that are being discussed. And so, with the right kind of transparency, the right kind of data, the right kind of analytic thought, and the right kind of planning of initiatives, we would hope collectively to move the needle in a more effective way. And so, we've already, the first panel was great, and we're going to open up now with some prompts to you all, hoping that you'll respond with into the Q&A to comment further. But there are some questions here that we've already started to delve into, and I'll put the first one out there, which is, where should there be prioritized efforts to mitigate cost growth? We talked about that in a number of different ways, observations on the previous panel of where we think there's opportunity, observations about what the data tells us, some of the challenges we have in terms of being a PPO state. But I think what we'd like to do here in this moment is to hear more from all of you about any comments you might like to make, or questions you might like to ask, or answers you might want to provide about this issue of where should our priorities be as we look at this issue of mitigating cost growth. We obviously didn't meet the target on this first round. What do we need to do to get there? So I don't know, Michael, if you might help by
Yep.
processing any of those questions.
We've
or
got
answers.
a comment from Pano Yarkaris. He notes other states have made greater progress. Let me start over again. Other states have made greater progress adopting models, including hospital global budgeting and primary care capitation. Any specific comments on those two areas? So I think Pano is suggesting that we should prioritize efforts to move towards non-fee-for-service payments, such as hospital global budgeting and primary care capitation.
So I guess we heard from Dr. Finale the importance of incentives and how those influence provider behavior, right? And Michelle had outlined that one of our very next steps is to convene this subcommittee to work on the specifics of value-based payments. So I think that that's, the consideration of incentives and their role in giving us the results that we see today, and how we're going to change those. Setting up the subcommittee to take a deeper dive is certainly, I think, a good way for us to pursue that opportunity. But I would welcome comments from Michelle or any of the attendees.
I totally agree. I think what we've been talking about, and I know we've talked about this among ourselves, the co-chairs, I think the biggest impact on cost growth is going to be changing the payment model. And so that's where I think collectively, I mean, that's the great thing, Al, as you started to say, the state, we've got a small state and all the players at the table who've all signed on to this cost growth target. That's really, I think, fortunate. And so we've got an opportunity. We're at a point in time where we should collectively work to really prioritize that work, because that's going to have the shortest, I think, term, longest, biggest impact.
And, I guess I would add, right, that Megan cautioned us a little bit that looking at our year over year cost performance in various categories, we may get into a little bit of the game of whack-a-mole that everybody talks about as things fluctuate some from year to year. The attractiveness of the value-based payment strategy is that it's more of a blanket approach that could influence many categories of cost growth. And I guess I'll just take a second to call out one of my favorite themes, which is that, and I think we've talked about this enough, and it's certainly part of our go forward strategy, is that if we want to control cost growth, we want to look at what trend looks like in different categories in any given year, but we also want to look at absolute levels of cost and absolute levels of utilization. And that was called out on the previous panel, where even if it didn't go up this year, if it's been running high for the last 5 years in terms of some category of price or utilization, those are places where it would be fruitful for us to attend to. And I think that's all part of what happens under well-executed approaches to value-based payment. Michael, do you want to give us some more from the Q&A?
Paraphrase a comment from Matt Collins, who observed that there's some wide price variation within the state, and I think believes that there's an opportunity to mitigate cost growth by engaging consumers, but notes that health plans have offered products that have cost transparency and incentives to choose lower cost options, but there hasn't been a lot of adoption of these products. So maybe we could explore whether engaging consumers and activating them to take advantage of price variation offers an opportunity.
Yeah, this is Jim Finale. Mike, I'd say that those generally can work. I think in a small state where you have limited options, it's pretty tough. I mean, again, I'll use the OB example. I mean, obviously the cost per delivery at women and infants is a hell of a lot more than it's going to be at South County at Newport, but it's because you got so many other things there. So I think that might be one of the reasons why they've had little traction, because we don't have a lot of options at this stage. If you go into Massachusetts and some health plan does a deal with the BI Leahy system versus Tufts versus the Mass General Brigham, you can probably get some choice limitations there where people will be comfortable going to one of the other providers. But I don't know whether, Al, you think that or whatever. I think it's kind of tough to think that those limited products or the trust transparency will get people to go one place or the other.
Well, I wonder too, how can we help consumers make an informed decision? Because I think that it might be human nature to think that the more you pay, the better the services that you're getting. And without some kind of sort of cognitively accessible set of facts to help people understand, where they're going to be best served, it could be pretty confusing to just look at pricing in isolation and try to make a decision, right?
Yeah.
Hi, this is Sam. I'm glad, Matt, that you posed that question. I think that those cost transparency initiatives, it's so difficult for consumers. Those of us who work in this field every day, and it's easy for us to forget how Byzantine this system is to the average consumer. There's a lot of healthcare that is not really shoppable. And if it is shoppable, it is extremely difficult to navigate. And I actually think there's a lot of promise in price transparency from the policymaking perspective. I think right now, those of us on this panel, those of us in this virtual room right now, don't really know what different providers are charging for different services. And that makes it very hard for us to design effective policy interventions to get at cost growth. So I agree that price transparency can be important, and I actually think it holds a lot more promise in the policymaking sphere than in the individual consumer choice sphere.
Can I just add one thing? Just to layer on to what Sam said, I also wonder whether price transparency and providing that to the primary care provider will be helpful. Just a more sophisticated stakeholder in the system to help guide, as opposed to just leaving the consumers to use the tool. Maybe that's one of the ways that in the future can help guide that, because there is huge variation, even in this small state, even on services which could be shoppable, like imaging.
We actually made a small foray into trying to share some price information with our primary care docs, but I think it's a lot to ask of them too, because there's so much that they're already trying to attend to. Sam, your comments about looking at price from a policy perspective are kind of resonant for me. And Michelle, I wouldn't reject it out of hand, but I think it's a hard thing to do. And it also is probably a role that neither providers nor patients are yet comfortable or familiar with. So if we were going to try to contemplate that, I think we would have to be pretty thoughtful, and it might take some time.
Okay, we have
Sorry,
another suggestion.
I was going to add, sorry, quickly, even for something that seems easily shoppable like imaging, it is harder for the patient than we realize. I just, from personal experience recently, the orders get sent to one, when you're in the office, you talk to the provider, they send their order, you want the order sent to a different place, it's multiple phone calls. Not every imaging provider has the imaging go right into the EMR of the specialist who you're working with. There are lots of tons and tons of really difficult friction points toward real shopping based on price.
So I want to share an observation and then the next suggestion we have, and that is there is experience from Minnesota where the shopping, and this goes to Beth's point about HMO products, where the shopping was done at the ACO or accountable entity or systems of care level, and for organizations that had a lower total cost of care, risk adjusted, and had good quality, there was evidence of movement on the parts of patients to those providers. It wasn't on a service specific basis in the way that Sam was just talking about. Right, so the next comment we have is from Jeffrey Borkan, who asks, should we have a statewide health services planning board with the ability to modify both spending and provision of care?
So I can start and jump in on that. So I think it's a really good question. I think the question of sort of governance at the state level governance with authority, I think is a really important one, as I said. And I think certainly as we recognize how much our delivery system is changing in the state, as we really do successfully, I believe we will accelerate the move toward advanced value-based payment. This is the work that Dr. Gross and Michelle were talking about, that we are prioritizing as a steering committee and collectively, because we really do believe the promise that holds to shift the incentives in the system and create a system that really does work for both patients as well as on both from a quality as well as a cost perspective. I do think we should be very open to thinking about what kind of new regulatory structures in the state make sense. It may be that our existing structures are adequate by simply adding authorities, for instance, to existing agencies, or it may be that a new structure that builds on some of the successful structures we have in state government already are warranted. So I think I'd be open to it. I personally, I'm not sure immediately that a separate statewide body is necessarily the best model, but I think we absolutely should be open to it and look at it rigorously. And I think we should look at it in light of our goals of what don't we have, what authorities don't we have in government and in policymaking to have the most impact, and then we should build our structures around those. But I think that fundamentally has to be informed by how the delivery system is likely to evolve, and it has to be something that reaches across the provider space and the payer space, as well as taking into account first and foremost the impact on consumers. So that's how I think of the question. But I think it's a very timely question and one that we are going to need to grapple with as a state in the coming months and years, without question.
I've got another one. It's a suggestion that there be attention and focus to the social and environmental drivers of utilization to ensure better population health. So I think it's a question of whether addressing social and environmental determinants of health or drivers of utilization would be a mitigation strategy.
I mean, I'll comment. I obviously the AE program is designed to move us in that direction. by facilitating our engagement with community-based organizations. And, I think that getting the incentives right, getting the value-based payment models right provides a mechanism whereby we can start to more effectively address social determinants of health and environmental determinants of health, and be able to support that, the time and the energy and the financial resources that we put into that by having the right kind of payment model. I think that probably that's an area where we could do more collectively, because I'm not wholly convinced that the short-term way that most of our payment models work today is really going to support the kind of robust interventions in those areas, because the sort of return on that investment sometimes is going to play out over a longer period of time. I guess as you start to look to issues like housing and transportation, some of it is short term, some of it is longer term. I think it's a great area for us as a steering committee, and as a community, as a collective to talk and think about it. Because when you look at the incentives, and then you look at the time frame over which costs are going to improve, it sometimes doesn't quite work with all the payment models that we have today, I would argue. I'd love to hear from others, either in the either folks who are mic'd or through the Q&A.
So this is Beth Roberts. I agree 100% with your comments. I think health plans spend a lot of time in this population health space, working with the provider community to have the appropriate alignment to get people the necessary services outside of the traditional healthcare services, to look at the patient more holistically. I would say what you said is perfect. Getting to value-based payment coupled with that, where we're working in unison with the provider community, again, the patient and the health plan collectively, is going to bring tremendous power to that.
Yeah, I would just pile on. I 100% agree. And I think, we know based on the data that health outcomes is a significant portion are, driven by the social determinants. And I think particularly this is a point in time with all the funds coming in from the American Recovery Act, where there are going to be more funds dedicated to addressing some of these systemic issues that have such a huge impact on health, that this is a good opportunity for the steering committee to think about how we could focus on that as well, in addition to the work underway.
Yeah, I think that's a great point, Michelle, because you can't always just get the 1-year return that's going to help you cover your expenses if you're taking this on sort of strictly from the provider perspective. So having that type of government financial support to be able to invest in the long-term benefits for the community, that seems like a highly rational approach.
Lots of ideas being generated. First, we have a historian who notes that 50 years ago, Rhode Island had a negotiated global cap on hospital spending. And so we would be going back to the future, so to speak, if we pursued that idea. And the precursor health plan to United experimented with specialist-based risk pools based on PMPM capitation. Both programs were ultimately ended due to problems. Lou Giancola asks, should we focus on reducing administrative costs, especially related to processing claims? And I guess he's wondering whether that's an opportunity for cost mitigation. Any reactions?
Well, I don't know if we want a health plan to respond to that question or not. This is Beth Roberts again. Of course, like everything should be considered, but I would say administration is such a small component of the total cost. Really, if you just think of it in big numbers, 85% of the cost is about delivering care and paying for the delivery of care. 15% typically in that neighborhood is for the administration. So I'm not saying it's small because healthcare is expensive, but certainly everything should be thought about.
Yeah, I agree with Beth. I think health plans have an obligation, but it's such a small portion of the overall cost that we know that the cost of health insurance is driven substantially by the cost of healthcare services, and that's where we should focus on where the money is.
This is Sam. I don't want to speak for Lou Giancola, but I wonder if he was also thinking about the provider-based costs that are created by our complex administrative system. And I think if you look at those costs, in addition, it's not just about the 15% of the net cost of providing health insurance. I think it's the costs that end up going throughout the whole system. And I think there probably is a lot of opportunity there.
It's a fair way to look at it, Sam, in my opinion. There's administrative costs on both sides of the house, for sure. It gets back to the total question of, if we lower that administration, do you see a blip in the medical cost on the other side? So it just needs to be looked at as a whole picture.
Yep. I also think, a related way to look at the interaction between administrative burden on the provider side, Sam, as you say, and in particular as it relates to being connected to the move to advanced value-based payment, as we talked about. I do think something that at least I've heard over the years, I think many people attending today have heard and engaged on, is the burden that is placed on providers, for instance, related to having to not just do claims payment, but obviously having to adhere to radically different value-based constructs across payers. And again, that's not to say that we want to have complete uniformity, because there's an important role, I think, for some degree of innovation in the market. But at the same time, I think one reason, again, in Rhode Island, we moved to an aligned quality measure set. I think that's been pretty widely recognized as significantly reducing provider burden and leading to more aligned results on quality of care and outcomes. And so I think where uniformity makes sense, I think, in addition to efficiency, to reduce provider burden and allow them to focus on the drivers of reducing cost and improving quality, I think that's always worthy of consideration. Recognize that that's a slightly different distinction from the, strictly speaking, administrative burden of like claims processing. But I think the issue of where we create administrative complexity and we can reduce it on both the payer and the provider side, and as well on the governmental side as well. I think that's in our interest to try to streamline all of that. And there's probably collective accountability there, as there is in most of these areas.
All right, one last question. Deb Hurwitz asks, should we revisit the Choosing Wisely guidelines as a state? For people not aware, the Choosing Wisely guidelines are clinical practice guidelines intended to reduce provision of low-value services.
This is Jim. I would promulgate those as much as we can. I think they're pretty good guidelines to try to get the public to realize, and for providers to realize, what things are not of value and what things are.
And I have to chime in because Dr. Finale and I agree on this. I love the Choosing Wisely campaign. I think the core element of it that's so important is it's based on that relationship between the provider and the patient, and making sure, that's who the patient trusts, and just trying to drive that relationship. I'm with you, Dr. Finale.
I think we're going to be circling back to the steering committee pretty soon with some additional data with regard to low value care, which isn't necessarily the last word on this topic either. But I think as we've done with our approach to everything, we'll try to be quantitative in this regard, and I think that's coming in the next month or two. I know we have other public discussion questions on the slide here that we didn't call out specifically, but I feel like in our conversation, we've really sort of covered them. Michael, is there anything else that you're gleaning from the Q&A, or?
Yeah, there's some other comments, but they're not so much recommended strategies.
So I will be brief, as Al said, and just start off again by thanking everyone, both our panelists, members of the steering committee, and members of the public for attending today. This really, I think, was a very constructive and very sophisticated conversation about not only our performance on the cost growth target, but again, what are the important steps that we need to take and to really initiate that conversation to ensure that in the future, we make every effort collectively to make healthcare more affordable for Rhode Islanders. The two themes for me, I think there were many today, but two themes that were through lines for me that I heard throughout the multiple discussions today were both the importance and the criticality of collective engagement. And that is something I think is a huge strength of this work that I think we have to leverage even further going forward. But I think there was a widespread acknowledgement that I heard, not only a widespread commitment by all of the participants in the system to continue to engage in that collective effort to make healthcare more affordable, but to be concrete and develop strategies that are actionable, evidence-based to do so. So that was very heartening to me, but I think it was a clear theme. And then secondly, going right along with that was the importance of thinking about and actually moving forward with an acceleration toward advanced value-based payment, that can serve all of constituencies in the system, first and foremost, patients and consumers, but certainly employers, purchasers, payers, providers, to create the kind of healthcare system that we all believe is needed. So with that, I'll thank everyone again for their continued engagement on this important work of the Rhode Island Healthcare Cost Trends project. And I think if we keep this work up, we are going to continue to make material progress toward making care more affordable for Rhode Islanders. So thank you, everyone, and I hope everyone has a good weekend.